So what do we do with all this? So there's been a number of different meta-analyses that have looked at this information, but none like this. So this is the Hermes meta-analysis trial. And what this was is this took the individual patient data from all 5 of these trials. And what this was designed to do was give us enough power to look at some predefined subgroups that all the individual trials could not tackle on their own just due to their size. And so this is a unique meta-analysis in that it represents all of the patients, so almost 1,300 patients. And what this did was it looked at the pre-specified subgroups. And when you look at the collective effort of all 5 of these, it requires only 2.6 patients that is the number needed to treat for 1 point of modified Rankin improvement at 90 days, which is a tremendous achievement. To say that this type of intervention is that impactful for patients is really quite wonderful. And so here is the control versus the interventional populations. These are these plots that I've been showing throughout the day. This is them collectively looking at the effect. And so you can see here's that 0 to 2 range, and here's the 0 to 2 range in the control population. And so what this tried to do was look at patients who were ineligible for IV TPA versus those that didn't. And you can still see even in the smaller number, again, it's only 80 and 108 patients, these patients meaningfully had an impact in terms of receiving a stroke intervention, even if they did not receive IV TPA. This is a busy slide, but what this is just showing is that the odds ratios for those patients that modified Rankin for 0 to 1, 0 to 2, and then the NIH stroke scale scores at 24 hours, and as well as early neurologic recovery. And you can see they're all very robustly positive in the adjusted ratio, and here's the absolute risk difference here. You can see that. In terms of the safety, the intracranial hemorrhage rate, as well as the Pringle type 2 hematomas, as well as the mortality, were not meaningfully different. Here are the odds ratios for those, and this again just showing what we already know to be, which is that this is a safe intervention and ultimately helpful for patients. And then this is this kind of busy forest plot at the end, but what this is just trying to show is that in almost all of the pre-specified subgroups, save for the ones that I'm highlighting in red, the effect was statistically significant in favor of intervention. The only ones that it had trouble with were for younger patients. Again, it's a smaller number. Again, it was still trending positive, but for younger patients, patients with very, very poor aspect scores, again, 0 to 5, those patients with M2 occlusions instead of obviously more proximal MCAs, and patients with low stroke scales. And so there are ongoing studies now trying to look at this issue, but this remains an area of controversy, is what do you do with patients who are either too well or too sick to receive intervention? The point, again, I would make, though, is that even in these cases where there wasn't statistical significance, they are all still on the favoring intervention side of things, meaning they're still trending in that direction, which is important because to just exclude a patient based off of one of these criteria, I think could be dangerous because there could be benefit for that individual. So this brings me to the American Heart, American Stroke Association guidelines from 2015. I'll try to briefly go through all this. The big point is that these are all in the slide deck and you can go back through them and read them as you like. I believe this will all be put into as a PDF, so it will be available to you. Should also know that these are also available online if people want to read the entire guidelines and all that put out by the AHA. So this was rapidly updated. You can see here their previous guidelines were in 2013. That was largely based off of the IMS-3 data, which was not in favor of intervention. And so when you had this landslide of data, they had to quickly pivot and come out with a new statement. And this is the kind of levels of evidence that we use in terms of assessing things. This is the strength of the recommendation from 1 to 3. And then the quality of the evidence itself, A through E here. A obviously being the best and class 1 being very stronger in terms of the recommendation. So I'm not going to read through all these. Suffice to say that they obviously came out very strongly in terms of the class 1 and level of evidence being A, that endovascular intervention should be offered to patients with, in terms of stent retriever, if they have a reasonable premorbidity score or pre-intervention health condition, that they've received IV TPA within 4.5 hours, that the occlusion is in the internal carotid or the proximal M1, they're an adult, then they have an NIH stroke scale greater than 6 and an aspect score of 6 or greater, and that the treatment can be initiated within 6 hours. And so this is right down the pipe of all of those trials, kind of coming down that we just discussed. These are wordy slides, but essentially what they're just saying is that when you get into patients who are outside of 6 hours, so this is like Revascat and other types of wake-up strokes and things like that, there could be benefit to these patients, but there is no true randomized data to helpfully, to definitively answer that question. And then obviously for patients who could not receive IV TPA, there still may be benefit. And we see that in the Hermes data, even though that's a meta-analysis. In terms of patients in other locations outside the M1, so these are more distal locations, it's indeterminate, but these patients still can obviously receive some benefit. The same goes for children. And so these are for people under 18 years. Again, this is rare, but it's a new recommendation suggesting that those patients should be considered for endovascular treatment. As for patients who are more morbid, either more less morbid in terms of the average stroke scale or more morbid in terms of their aspect score, again, these patients we were talking about in the Hermes sub-data, that there may be benefit, but again, we're not exactly sure, and so additional studies need to be done. And then lastly, moving on, this talks about some of the treatment devices themselves. It talks about the use of a proximal balloon guide catheter. This helps reduce additional perfusion to the brain when you're pulling out clot, as well as the use of non-stent retrievers, and these are suction aspiration systems largely. The data isn't as strong, but again, they did say that these could be useful. And then finally, this gets into some of the other issues around technique, as well as the use of conscious sedation. And so there are some other types of studies looking at use of general anesthesia and versus sedation for stroke intervention. Again, I don't want to read these all to you. You can read them at your own leisure. Suffice it to say that you should all be familiar with these guidelines and how they affect your practice. And then this is just talking about some of the imaging themselves, how we use CT and CTA, MR and MRA, and how we use perfusion to help select patients. And so this really speaks to some of the data that we got from Extend-IA and from Escape. So in terms of a conclusion, obviously, it goes without saying now, the mechanical thrombectomy for TPA for patients leads to faster and more complete reperfusion. And then in selected patients with large vessel occlusions, this is clearly the standard of care now and should be offered to any patient as such. So the things that need to be determined, wake-up stroke, I should first of all say there's probably close to almost 100 clinical trials that are now ongoing, that are being started or at least recruiting, that are trying to answer some of these additional questions. Some of them are redundant, but some of them are trying to uniquely answer certain things. So the wake-up strokes, patients who have an indeterminate set of onset because they wake up with their symptoms, that's the DAWN trial. Treating patients beyond 8 hours, that's the diffuse trial. UCSF is actually a site. And then treating patients with lower aspects in posterior circular lesions is the basic trial, which I mentioned kind of just briefly at the beginning. Obviously, patients who are not receiving TPA, there are trials looking at this. And then the effects of anesthesia. The Siesta trial was just recently published, but there are a number of other trials looking at the effect of general anesthesia versus conscious sedation in patients with acute stroke and how they should be treated. But the stroke world is very, very busy at this point. I think there's a lot to know, but a lot of it is very accessible. And again, I can't underscore enough the role of teamwork in terms of treating these patients. That's probably the most important part, that everybody from the EMS teams that deliver the patient to, the nursing that happens after it's all over in terms of, swallow studies and evals and everything between. It's essential that everybody move fluidly through these processes to really, derive as much benefit as possible from treating stroke in the acute setting. Thank you.